kind of an adventure for us all, but so far it's worked very nicely. So what the three faculty members are going to do tonight, are we're going to take you through three reasonably typical cases of high-resolution CT that are actual cases from the ACR Education Center, and we'll go through how you as a participant will go through each case. Let's just start with the first case here. So the first thing you get is the case history, as you see. 55-year-old with asthma and increased dyspnea. Pretty typical, not very helpful history. So now the next thing we'll come back to this case engine, but the next thing we'll do is go to the images. Thanks, Kerry. Already these are, so just so you know, I had asked Kerry, we've worked through this in advance, and Kerry has just given me a couple of series that I know I need to see. But for your experience at the ACR Learning Center, you will have a full DICOM data set that includes complete high-resolution CT imaging plus contiguous imaging, and usually plus coronal and axial, coronal and sagittal reconstructions, and expiratory imaging as indicated. So for the purposes of this demonstration, we're just going through these high-resolution selected non-contiguous images. They're 1.5 millimeter thick, and I think they're maybe 10 millimeters spaced. So here at the very top image, you can already see that this lung parenchyma is abnormal, with a mixture of ground glass abnormality and maybe some centrilobular nodularity. I'm just trying to advance here, and it's not advancing for me. Here we go. All right, just a little bit of a lag. So let's go back up. I can. Okay. So on this image, you can, I think, perceive a little better that there is, in addition to the background ground glass abnormality, there is this poorly defined centrilobular nodularity. And let's see if I can go down a couple more images. Okay. Not that many. Thank you. And you can see these poorly defined centrilobular nodules. How do we know they're centrilobular? It's because when we look out at the lung periphery here, we can see that they're separated from the pleural surface by 1 or 2 millimeters, and they're separated from each other. They're beautifully evenly spaced. Now, as we go down to the bottom of this, you can see that we have, can we go back up a little bit, a mosaic attenuation pattern. So you can see in the middle lobe here, in the lingula, we still have the ground glass abnormality. In the lower lobes, we have decreased lung attenuation. And there is also some airway wall thickening. So the question that immediately arises then is whether this mosaic attenuation pattern is due to air trapping or due to something else. So the next thing we're going to look at are the expiratory images. So now we're going to scroll through the expiratory images. And you can see that, if you stop there, Kerry, please, that those areas of decreased attenuation on the inspiration scans are retain gas or show gas trapping on these expiratory images. So there is quite extensive mosaic air trapping as a component of this examination. So let's go now to the case engine. So this is, as Scott says, one of the unique aspects of this course. When you have finished your review of the case, and you would almost certainly take more time over it than I just did, but again, this is for demonstration purposes. You will be presented with this list of choices for first of all, the pattern of abnormality that is present, also for the distribution of abnormality, and finally for diagnosis. So we'll work through this together. These nodules, we've decided, are clearly centrilobular, and they are poorly defined, and they are of ground glass attenuation. Okay. Additionally, we talked about the fact that there are also areas of increased attenuation or ground glass abnormality. These are patchy, and they're clearly upper lung predominant. In some areas, they're a little geographic. And then the morphologic characteristic is that they are poorly defined or ground glass. The third category of abnormality that we see here is that there is decreased attenuation with a mosaic pattern that we talked about, and with air trapping, and that there is also lower lung predominance. These are not filling in for me, but this is just because of the remote access, I think. Also, we've clicked down here, and these are areas of lobular decreased attenuation. Okay, let me just try this once more. There we go. So we have mosaic attenuation and expiratory air trapping. So now we're going to scroll down. Okay, so I think I now have control. We look for ancillary findings, of which there are none. Again, I can tell you that because I went through these images before. And then we are required to give a radiologic diagnosis. So what's our most likely radiologic diagnosis here? It is hypersensitivity pneumonitis. This combination of centrilobular nodularity, mosaic attenuation, ground glass abnormality, and expiratory air trapping almost certainly represents hypersensitivity pneumonitis. If you want, you could also say, well, maybe this person has some other form of cellular or inflammatory bronchiolitis. So we'll just click that, but honestly, these features are absolutely typical for hypersensitivity pneumonitis. The next finding, which is an important part of your HRCT report in practice, is, well, what additional tests or management do you recommend? So since we think that this patient has hypersensitivity pneumonitis, I think it'll be very important to do a thorough clinical evaluation and ask specific questions about exposures. We will not do a surgical lung biopsy, but usually these patients get bronchoscoped, and they get bronchoalveolar lavage and transbronchial biopsy, and that's usually sufficient to make a diagnosis, providing the clinical history is compatible. So we will now submit the case engine. It tells me you have completed the case. This patient it summarizes the findings. Profuse, poorly defined centrilobular nodules, mosaic attenuation, air trapping, as we discussed, typical for HP. So this was hypersensitivity pneumonitis, and in this case, the exposure was hot tub, which, as you know, produces mycobacterial organisms, can be aerosolized, and results in HP. You can also, if you're curious, you can access the actual radiology report, just to see how that was, how that read. And in many of these cases, we also have associated physiology. So in this particular case, here's a flow volume loop. Here's the normal, and here is this patient showing marked impairment of expiration, marked expiratory flow limitation, and also increased residual volume corresponding to the air trapping that you saw. So that completes this case, and we'll move on to the next case. Well, we can take any questions now. Are there any questions? I can't hear anything.
Yeah, Sek, if anybody has any questions in terms of the case, then please let us just go ahead and type them in, and we will go ahead and ask the Dr. Lynch to answer those questions. So one of the questions here, Dr. Lynch, is do you always need to do expiratory scan?
I believe that expiratory imaging is a critical part of the HRCT. Some people only do it when they think their airways disease is present, but this case is a particularly good example of this patient has what would be defined usually as an interstitial lung disease, and the indication for expiratory imaging would not be necessarily apparent, but you can see that it really added to our diagnostic confidence in identifying the expiratory gas trapping. So I believe it should be routine in every case. We do just expiratory scans, one every 2 centimeters or something. So it's really not a lot of extra time or a lot of extra radiation exposure, and saves you bringing the patient back if you have a surprising finding.
All right, thank you. The next question is, do you actually make the differentiation between acute and subacute HP?
That's a good question. I don't believe that I can. I could see this same pattern that you've just seen in somebody with a 1-day history of HP, a 1 month, or a 1 year. So I don't think we're particularly good at identifying the duration of the HP, even though that's the way a lot of the books and papers read. I prefer to just distinguish between fibrotic and non-fibrotic HP. Obviously, if you have fibrosis, you have more chronic HP.
All right, great. The next question, are you performing low-dose technique?
We certainly have cut back on our dose significantly. I don't have the dose, we'll go through that in more detail, when we actually do the course. We used to do 200 MAS, now we're down about 100 or less than 100 reference MAS with dose modulation. So we have reduced our dose. Most of us don't feel comfortable around the 40 MAS level. We're concerned we might miss some ground glass abnormalities, but it's a bit of a complex topic that we cover in more detail in the course.
All right, we'll have time for just 1 or 2 more questions before we have to move on to the next case. The next question, can you show could RBILD look similar with air trapping too?
Well, that's a great question. So RBILD certainly gives you those poorly defined centrilobular nodules and can give you air trapping. However, several things are helpful. Number one, I've never seen a case of RBILD with nodules that are this extensive and profuse. Secondly, the degree of even though RBILD can be associated with air trapping, I don't think I've ever seen it with mosaic air trapping like this, those sharply defined lobular areas of air trapping. And then thirdly, if you're still in doubt and it's reasonable to put it in the differential, you can always check the history, because RBILD is a smoking-related lung disease, and it's actually really rare for smokers to develop HP. So if the patient is a non-smoker, it's almost certainly HP. If the patient is a smoker, it's almost certainly RBILD.
Okay, we have time for just 1 more question. Can you see lymphadenopathy with HP?
You can see lymphadenopathy with any diffuse lung disease. We call it reactive adenopathy. So it's kind of unhelpful in making the diagnosis. If you see very large lymph nodes greater than 2 centimeters, you might begin to think more of sarcoidosis.
Great. Thank you very much, Dr. Lynch. Thank everyone for your questions. In the interest of time, to make sure we get to the other cases, we will have to move on now. So we're going to move on to the next case, and Dr. Nadich now will go through that. And so we will now transfer the controls over to Dr. Nadich.
Well, hello, everybody, and welcome. It's really thrilling to see so many people signed on. I'm going to reiterate in most ways what Dr. Lynch has just done, which is to go through the process of how each of these cases that you get to work through at the ACR headquarters is done. Consider that we are, however, only going to go through a handful of cases tonight. We have well over 150 or maybe even more now cases. I should also point out that as part of the process, while you're reading through all these cases, we also intersperse that time with several lectures, and those lectures tend to be organized around groups of interstitial lung diseases to try to clarify how to think about approaching all of these otherwise potentially confusing and overlapping diseases. So with that introduction in mind, this particular case history is a 29-year-old male with a chronic cough. Now, the way these cases are set up may vary from case to case. So in this particular case, we also have chest x-rays. We have two different study dates. I'm not sure I'm going to be able to go through all of that with you. So you have to read very carefully, because sometimes the critical thing is to see the follow-up. Sometimes it's the critical issue is to see what the initial and then the response to potential therapy is. And then, of course, a lot of cases will also have, in addition to the kind of pulmonary function test details that Dr. Lynch showed you, there will also be pathology and so forth. So every case is actually just a little bit different in terms of its presentation. Almost all of the cases, I would point out, and something we're not going to go through this evening, almost every one of them will also have 1 millimeter or 1.5 millimeter thick sections contiguous through the entire chest, so that although we're going to show you and emphasize the high-resolution images taken every, say, 10 millimeters, the much richer and much more detailed data set is invariably present for you also to review. So with that in mind, I'll show you a chest radiograph. There are some ill-defined nodular densities that we can see. I think you agree the heart is normal in size. Certainly there are no effusions. The hilar are a little full, but I don't think they're dramatically abnormal. I think you might be willing to pass the rest of the parenchyma as pretty much normal. Carrie, can we advance to the next set? So I'm going to take you, once this sort of like settles in, through the images. One of the other advantages, I think, of being at the ACR is that while there's huge agreement between all of us in terms of our general approach and so forth, there are subtle differences. So I like, when I go through a case, to be able to review the entire series first before I say anything about it. So I like to go from top to bottom. So that's what I'm going to do rather quickly. These are all 1 millimeter thick collimated images. And then I'll go back up again to just get a better sensibility of what's happening. So I think some of the things that become obvious right away is that there are a lot of nodules in these lungs. If we could advance again a little bit. I'm not seeming to have control over that, Carrie. There we go. Let's stop there. That's good, right there. So there are a lot of nodules, and I think one of the things that we always try to emphasize is to come to some kind of decision early on as to what the primary abnormality is. As you're aware, a lot of these cases have a lot of different features that might overlap, but almost invariably there's going to be one or two, stop there, that's good, one or two images, or one or two characteristics, rather, that really define the case. So if we look at this case carefully, we realize there really are a lot of nodules. And those nodules are poorly defined. They're pretty much the same size. And if we look along the fissure, for example, here, you'll notice that that fissure is studded with these small nodules. If we could advance a little bit further, just a touch, Carrie. Good. Go back up one, if you can. Some of these nodules are clearly along the pleural surface. Clearly they're along the fissure over here as well. And you'll notice that there are some areas of somewhat more coalescent density here. which are, in fact, areas of coalescence of these smaller nodules. Let's go up a little bit higher, if we can, for a second, and see if we can find some other features that are, that would be good here. No, that's perfect. Stay there for a second. If you look carefully, again, along the fissures, you can see all these tiny little nodules. Some of them are along the pleural surfaces. You'll notice that the airways are also thickened. They're, in this case, fairly uniformly thickened, but the fact that these central areas of lung, rather bronchi, are abnormal is certainly suggestive that the axial interstitium, that's the portion of the interstitium that's central on which the main vessels and the airways traverse, may be involved. If we could go very slowly down, Carrie. I'll go back up one more, go up two, stop, one more. Yeah, stop there. You'll notice, for example, well, it's hard to get control of this. Here again, you'll notice that this airway is thick-walled and is out in the periphery. And if you look carefully, you realize that there's some nodularity along the course of that. Now, if we could switch over, I'm sorry, before we do that, if we could go to the lung bases, you'll notice as we go inferiorly, these findings start to fade out a little bit, and by the time we reach the lung bases, it's pretty much absent. So that this clearly is a nodular disease. It has characteristics that are perilymphatic in that they are along the airways, they're along the fissures, they're along the pleural surfaces, and they are in some areas coalescent to give you a somewhat larger nodular opacities, and they're clearly upper lobe in distribution. Now, if we could go to the mediastinal windows for a second. I think while we're transferring over, one of the things that's truly striking, I think, and I think most of us are already aware of this, the extent to which the lungs are abnormal, where the chest radiograph really is grossly underestimating the true extent of disease, let alone its characteristics. So if we could scroll down a little bit here, Carrie, just very slowly. So there's really not much in the way of, keep going, significant adenopathy. There are some, go back up one if you could, or there, that's fine too, or one more up. There's some precoronal nodes that you can see here. Keep coming down. This is a non-contrast study, and I would point out that almost all of our high-resolution studies tend to be without intravenous contrast. There is some fullness in the hilar regions here, but I think you'd agree that this is not a study or a pattern of pathology with overwhelming adenopathy as its particular manifestation. So if we can go to the case engine now. And so let's see. Now, if we take a look a little bit more carefully at the way the case engine is structured, you'll notice that we have anatomic distribution of disease and then morphologic. And those are the two basic areas that we have to concentrate on and decide terminologically what's happening. And then in further assessing these cases, we have to make a judgment as to whether or not there are nodules or other reticular opacities. Is this a question of decreased or increased areas of lung attenuation, or is this really a primary airway disease? Invariably, there will be some overlap, as David Lynch showed you in the case that he analyzed. But typically, there's going to be one of these 5 characteristics that really dominates the actual decision as to what's happening. So we know that there are perilymphatic lesions here. We know that they're not random or miliary or central lobule, which pretty much characterizes nodules anyway. We're not impressed that there are any reticular changes. We did not do areas of decreased attenuation because inspiratory scans were not part of this. There was some evidence of airway disease here, so it would be upper lobe predominant, and it would be central for the most part. But again, the reason not clicking in for some reason, but they're not the major findings here. What about going back now, once we've decided the anatomic distribution, what are the morphologic characteristics? Well, these are poorly defined nodules. They're not branching, they're not cavitary, they're not calcified. But they're not really ground glass either. So sometimes you have to make a judgment that's not quite as pure as you'd like it to be. These are really not ground glass nodules, so we'd have to say, given these choices, that they're more sharply defined than they are poorly defined. Again, no reticular areas of concern. Areas of increased attenuation, there were some areas of coalescent disease, but again, these were not the primary abnormalities. Similarly, decreased attenuation in primary airway disease. So having said all of those, are there ancillary findings where there are a few nodes, mediastinal and hilar? But otherwise, I think we don't really see anything else here that would need characterization. So having said that, the way this works now is that these choices are actually predetermined by the answers that you come up with. So it's not going to be the same set of potential choices. You'll notice these are radically different, really, from the choices from the case that David showed you. These choices will reflect what you have chosen as the primary abnormalities as well as what the truth data set is. So I think we can agree with all of those findings that this really is a classic case of sarcoidosis. I don't think we really have to consider others, although other diagnoses are possible here. And then, again, continuing on, we can look at the recommended course of action. Clinical history is almost by definition going to be part of it. Some of us feel that these findings are so sufficiently characteristic that bronchoscopy is not indicated, but in fact it almost invariably will be. And of course, this will be a transbronchial biopsy. A bronchoalveolar lavage really has no role here. So we've looked at the case, we've filled out the engine, we've looked at the choices presented and made up our mind as to what we think it is and what should be done. We submit this. And then you'll notice that this is, in fact, classic perilymphatic disease associated with sarcoid. And it's classic in almost every regard. And it's a beautiful example, I think, of the whole issue of these tiny little nodules or diffuse nodular diseases that we have multiple examples of for you to consider. Be glad to answer any questions.
Sure. Would you like to go through the Rad Report real quick before we get to any questions?
Well, that's fine. I mean, I'd rather answer questions and spend time. It's very much similar to what David had before, which is invariably the actual reports that were generated at the time are available to you. If the path reports are available, those are also invariably included, and if we're lucky, we can actually include images. But this is such a straightforward case, I would much prefer to just answer questions if they're available.
All right, great. If you want to go ahead and anybody has any questions, go ahead and type them through. We've got the first one. Forgive my pronunciation if I butcher this, but one of the questions was, aren't the precarinal nodes of normal size?
They might have been top normal. You obviously have all kinds of tools available to you as you're analyzing these cases in terms of looking at not just density but size and so forth. I would have thought just eyeballing those that they were slightly enlarged top normal size. They certainly weren't the kinds of potato nodes that you'd expect to see in someone with stage 1 sarcoid.
Okay, great. Next question is, any chance silicosis would be considered with right history?
Silicosis certainly can give you a pattern of nodules, very fine nodules in the upper lobes. Some of the things that you might want to look for in silicosis early on might be a little bit more better defined nodules, sometimes a little bit more calcified. Obviously, if there's nodes, you might want to look for eggshell calcifications, which you actually can see in sarcoid as well. So the answer is that it is part of the differential, but the history almost invariably will lead you either to sarcoid or away from silicosis or co-workers pneumoconiosis.
Great. We've got a lot of good questions rolling in. See if we can get to most of them here. If pressed for a differential, what would you say?
Sarcoid. Not being facetious, I have rarely seen anything like metastatic disease do this. I think the notion of one of the pneumoconioses is a good one. I believe rarely berylliosis could also have this appearance, and maybe David, you could, if you're still on, chime in with that because you have more experience than I do with that. But frankly, a true perilymphatic pattern, especially if it's upper lobe, lower lobe sparing without nodes, is almost always going to be sarcoid. That's, I think, the rationale for why pulmonologists will do biopsies in these cases is because they're not entirely convinced that there may be some other diagnosis. When you push them hard to ask them what are the diagnoses they're really considering, the answer is rarely anything other. But they feel that it's necessary, if they're going to treat these patients, in particular with steroids, that they have a more definitive diagnosis.
Okay.
Yeah, Dave.
Oh. All right, go ahead, Dr. Lynch.
Yeah, well, I would just agree that, you know, chronic beryllium disease is a rare entity, but I usually put it in my differential just because it's surprisingly often missed by clinicians if they don't take the right history.
We have time for some more questions, yes?
Yeah, just two more quick ones. The first one is, sometimes I get confused with perilymphatic distribution and random distribution. Is there any good way to differentiate between the two?
Yes, absolutely. So random by definition is just that. So virtually any particular anatomic compartment in the lung can be involved. Having said that, the real hallmark of perilymphatic disease, and in particular sarcoid, is involvement of that axial interstitium. To be in and around blood vessels, especially those that are central, or the central airways, if they look thick-walled and beaded, it's much, much more likely to be sarcoid, and that's the real telltale. The other thing about sarcoid or perilymphatic is that, by definition, it tends to be more often asymmetric, and it's clearly more upper lobe in distribution, whereas random tends to be more often hematogenous and so more lower lobe. So that can also be of some value or some help in that regard. And I think that the idea that the airways and the axial interstitium are involved is the real key, which, by the way, is why of all the diffuse interstitial lung diseases that are most easily diagnosed with transbronchial biopsy, sarcoid is right on the top or near the top of the list because the granulomas live in the walls of those airways. So to see thickened and nodular airways in someone with a random pattern of nodules would be rather unusual. So that's the key means for differentiation.
Great, thank you. We have just time for one last question. Do you stage sarcoid in your reports? If so, do you use the same conventional radiography classification?
I often do very specifically suggest that this pattern is highly characteristic of sarcoidosis. As I say, referring physicians and pulmonologists will make up their minds quite on their own about what they want to do about that. And I never use the classification, I guess it's the scatting classification for what is in fact a pattern of distribution on the chest radiograph. Again, I say the same thing. If there's a pattern that I think is truly suggestive of sarcoid with symmetric adenopathy and some nodules in the lung, I'll say I think it's characteristic or suggestive of sarcoid, but I don't try to use any type of grading system or classification.
Great. Thank you very much, Dr. Nadich. A lot of great questions. Unfortunately, we just don't have time to get to all of them, so we can get through the next two cases. So now we're going to go ahead and give the presentation over to Dr. Jeffrey Caney, who will go through our next case. All right. Well, Dr. Caney might be having some audio issues. Give us just a couple of seconds. Thank you for your patience.
Can you hear me now?
Great, there you are. Thank you, Dr. Caney. All right.
Okay, I switched over to the internet. I'm sorry about that. Well, good evening, everybody. I just want to welcome everybody again. Thanks for joining us this evening. I was trying to say that one of the nice highlights about the course as well is getting to sit down with the faculty and discuss not just interpreting cases, but also sort of the mechanics of how to do these scans, how to integrate them into your practice, how to communicate with your referring physicians, and even details in reporting these studies, because using the correct terminology is very important for conveying a diagnosis and a level of confidence. So again, another one of the advantages in addition to reviewing over 100 cases. So our third case tonight is a 41-year-old woman with progressively severe dyspnea on exertion. And so now we'll pull up her images. Okay, so you can see right here we have we already have a coronal reformat. We have a 1 millimeter thick section, a 5 millimeter thick section. So we're going to start with the 1 millimeter thick section. And you'll notice the window level isn't set right. So because this is a PAX, we can actually change the window display right away. And so my approach is similar to that of Dr. Nadich in that I like to go through the entire case, just one quick scroll through the case. So I have an idea in my mind, what is the primary process I'm dealing with? Am I dealing with lung that's too light, lung that's too dark, nodules, clear-cut fibrosis, and things like that? And then I go back through it in detail and look again at morphology and distribution. So as I just go through this case real quickly, we can see there's a diffuse abnormality. And there are lots of black holes in the lung that go pretty much from the top to the bottom. And most commonly when we see black holes in the lung, we think about emphysema. But you'll notice, we'll stop here, for example, that these holes all have walls around them. They're very well defined. And within the middle of the hole, we don't really see much of anything. And often with emphysema, we usually see a dot representing the remaining artery in that lobule. So again, we see here diffuse low attenuation with confined walls without anything in the middle of these areas. So this is most consistent with a diffuse cystic lung disease. And we can switch again and take advantage of these volumetric data sets. And even just on one image here, we can see this is truly a diffuse abnormality. So the major differential diagnosis for cystic lung disease is pulmonary Langerhans cell histiocytosis, lymphangioliomyomatosis, and lymphoid interstitial pneumonia. And these all present in very different clinical settings, and their morphology on imaging is very different. Because this is a diffuse disease, we were going to think about certain things versus if it were upper lobe or lower lobe predominant. Just quickly looking through the case, we don't see any lymphadenopathy, we don't see pleural effusions, any abnormal calcifications. So now we'll turn to the case engine, and we will enter our findings. And one thing I do want to point out is particularly as you're starting one of the areas in the course, for example, we group diseases often by these patterns, you'll notice that a lot of these choices are grayed out. And this allows you to focus on this one area as you're learning. And as the cases become more difficult, as you get further into the data sets, you'll see that more and more choices become available, more like the real world, where you have to decide what's there and what's not there. So in this case, we only have areas of decreased attenuation to choose from. And we can clearly say it's a diffuse abnormality, and it doesn't fit any of these other things. We did not have expiratory imaging, so we wouldn't comment on this. And because these black holes in the lung had had walls, we're going to call them cysts, and they had very thin walls, less than a millimeter at most, a millimeter at most. And most of them were fairly round. Occasionally they get slightly distorted, but I would say most of them are round. These aren't cavities, and we really didn't see any emphysema. It would be possible to hide a little bit in there, but not enough to make us want to select that option. Again, we didn't see any ancillary findings. So now it presents us with a differential diagnosis. Normal is usually in the list. The correct diagnosis is usually in the list. And then sometimes the options are randomly selected based on these findings here. So the person sitting next to you might have different options, and so that you get a variety of options to think about. So in this case, this is a small airways disease here. It would be characterized by air trapping. We've discussed hypersensitivity pneumonitis. One could consider central lobular emphysema, but again, this is a diffuse disease, and smoking-related emphysema predominates in the upper lungs. Also, because these were discrete cysts, this is not likely to be emphysema. Lymphangioliomyomatosis, also called LAM, is a very rare disease, but it is characterized by diffuse cysts in the lungs. It occurs exclusively in women in the absence of tuberous sclerosis complex. And so we have and it's usually women of childbearing age. So we have a woman in her 50s with progressive dyspnea with diffuse cystic lung disease. So I would definitely check this as an option, and this would be my leading diagnosis. Cavitary infection, this is not the appearance of an infection. It doesn't fit with the history. I did mention some other cystic lung diseases. Langerhans cell histiocytosis is a disease of cigarette smokers characterized by nodules and cysts, and it has a very pronounced upper lung predominance with sparing of the bases. So that would be inconsistent. And I mentioned lymphoid interstitial pneumonia, which is usually associated with immune deficiency or collagen vascular disease, particularly Sjogren's syndrome. And that's characterized by far fewer cysts and often other findings such as ground glass, nodules, and septal lines. And the abnormalities typically have a basal predominance. So based on what the case engine provides me here, I'm going to stick with my diagnosis of LAM. And then the management of LAM has changed probably in the past decade. Many of these patients used to go to surgical biopsy, but CT has really changed that, and this is very much a radiographic diagnosis. So in this case, I would go to a clinical evaluation only, look for signs or symptoms of tuberous sclerosis, history of spontaneous pneumothorax, things like that that may point to that. But most of the time, these patients are diagnosed just based on a clinical history that excludes other diseases and HRCT, as in this case. And then we will submit our case into the case engine, and we get our description again, thin-walled cysts throughout both lungs without nodules, with a final diagnosis of LAM. We can pull up briefly the original radiology report. And this is also an area of discussion because sometimes the report doesn't agree exactly with what's in the case engine. And that's because this is the actual report that may have come from one of our institutions. It may be from one of us, it may be from a colleague, or it may be from an outside facility that was then referred to one of our institutions. And this just shows there is variation in how people report and describe things and even how they interpret findings. So this makes for some good conversation and better understanding of a case when we have this available. And then another thing, and also you can keep track of how many cases you've done towards your certificate. And if you have cases you want to flag for faculty review, you can click a button here, and one of us will come over and go over a case with you, and you can batch these up, and we can sit down and go over several with you. And so I'll take some questions now about this case.
Great. Thank you very much, Dr. Caney. We do have one more case to get to, and it's going to be a good one because we got the pathology that's going to go along with it. So in the interest of time, we can only take probably 2 questions here depending on how quickly we get through them.
Okay, that's fine.
Okay, so for the first question, so the cyst with wall, is it right to put emphysema with fibrosis as a differential?
Well, sometimes distinguishing fibrosis and emphysema can be difficult, but in general, when you have a diffuse cystic lung disease, there's really no distortion of the architecture. It's pretty much a replacement of the lung. We didn't see any traction bronchiectasis or anything like that to suggest fibrosis. And finally, with diffuse cystic lung diseases, the lung volumes tend to be overinflated as opposed to fibrosis where you would expect them to be underinflated.
All right, great. Second question, is there any difference of TS associated and just plain LAM?
TS associated is more common, and it's many of those patients lack pulmonary symptoms, whereas sporadic LAM, most patients usually present with clinical disease. There are some other findings of small nodules that have been associated with tuberous sclerosis, but my understanding is when it's severe enough in the lungs, it results in obstructive physiology and replacement by cysts, and the prognosis is really based on the pulmonary function.
Great. Thank you, Dr. Caney. In order to make sure we have enough time for the last case, we're going to have to move on.
That's
fine. So
fine.
with that, we're going to have Dr. Lynch and Dr. Travis, who will go through the last case with us. And so we're going to go ahead and give them the opportunity to present now.
Thank you, Scott. So here we have, so one of the highlights of the course is the availability of a real-life pathologist, and, you know, particularly Dr. Travis has supported this course from the beginning, and as you know, he's a world-renowned expert and wrote the classification of the idiopathic interstitial pneumonias as well as adenocarcinomas. So it's a real it's always a highlight of the case for us. What we do is usually on the third day of the course, we actually we give you these cases to preview. You can make up your own mind, and then we go through them as faculty with Dr. Travis. We review the features, and then we review the pathology, and then have basically a radiologic pathologic consensus discussion reflecting the importance of pathology in this aspect, in high-resolution CT. The fact that dialogue between radiologist and pathologist is really important in reaching, and clinician is really important in reaching a clinical diagnosis. So here's a good example of this. 73-year-old man with rather sudden onset of progressive shortness of breath. So we'll bring up the images. Okay, let me see if I have control this time. No, I still don't think I have control. So, Carrie, can you just advance? Good. So scrolling quickly through those images, you can see that this abnormality is lower lung predominant. And again, these are high-resolution images. In the upper lungs, we just have a relatively mild subpleural irregularity. As we go down through the lungs, you can see that we have a moderate amount of ground glass abnormality, particularly in that right middle lobe. We'll go back up there in a minute. Right there, which is, a little unusual. But then most of the abnormality is concentrated at the lung bases. We'll go down. That's good. Okay. And I'm not sure if you can see my mouse, but there is clear-cut traction bronchiectasis present bilaterally, and the other predominant abnormality is reticular abnormality. I think when I went through this case before, I found some areas of potential honeycombing. Go back up one or two. I suppose it's really not as convincing now, but this abnormality is certainly peripheral predominant and basal predominant, with reticular abnormality and traction bronchiectasis, and a moderate amount of ground glass abnormality. So can you show me the expiratory images? Or prone is fine too. Yeah, go back to prone. It's just prone images are useful, even though clearly the parenchyma is abnormal. Sometimes you just get a better delineation on the prone images. So we'll just scroll through these. Again, the subpleural irregularity in the upper lungs, clearly getting more marked as we march down towards the bases. And the primary abnormality is a reticular abnormality with traction bronchiectasis. Maybe some questionable honeycombing, but nothing very dramatic. We'll just look at the expiratory images because we want to be sure there's no mosaic attenuation or expiratory air trapping. And then we'll fill out the case engine. These are good quality expiratory images. And there is a little bit of mosaic air trapping, but really probably not enough to change our impression. So let's go to the case engine, please, Carrie. Let's see if I can fill this out. So notice that, as Jeff pointed out, we're in the category of reticular abnormalities. They are predominantly peripheral and subpleural. They are basal predominant. There is no subpleural sparing or basal sparing. they are primarily, I don't actually like the term intralobular, I prefer the term reticular, but they're certainly not interlobular, and they're really quite irregular. There is traction bronchiectasis, an architectural distortion, and questionable honeycombing. We'll probably leave that out for this purpose. So scroll down, please. Or maybe I can do it. I'm not sure. I'm not scrolling here. Okay, so let's just give our radiologic differential diagnosis. So the fact, so it's clearly we're in the category of fibrosing interstitial pneumonias. The fact that there is only questionable honeycombing at most means essentially that we're in the differential diagnosis between UIP and NSIP. Now, because of the peripheral and subpleural predominance, I would favor UIP in this case, but it's NSIP. Some cases of NSIP do look like this. So this is one of the indeterminate cases, possible UIP, where surgical lung biopsy is appropriate. So we'll submit this. Okay. And then, so peripheral predominant, basal predominant, reticular abnormality, no convincing honeycombing, NSIP versus UIP, favor UIP. Now we hand it over to Dr. Travis.
Okay, so we have a surgical lung biopsy from this case, and there's extensive fibrosis. There are a lot of cystic areas which correlate very well with what we saw on the CT. This is a pattern that some pathologists might call honeycombing, but I find it is a very good correlate with what radiologists call traction bronchiectasis. But histologically, we're looking at the level of a bronchiole. So I find this best described as traction bronchiolectasis. And I don't think this is true honeycombing. And in other areas of the biopsy, the fibrosis is very uniform with preservation of alveolar architecture, no fibroblastic foci, and so the lack of convincing honeycombing fibroblastic foci from the biopsy standpoint made me favor a pattern of fibrosing NSIP. There was a nodule on the CT, which we didn't have time to point out, but it correlates well with this intrapulmonary lymph node that was obtained in the biopsy. So pathologically, I regarded this as a fibrosing and cellular interstitial pneumonia, and based on the specimen that I had pathologically, I favored a nonspecific interstitial pneumonia fibrosing pattern. So I think it is a good case to discuss the differential of UIP versus NSIP.
Great. Thank you, Dr. Lynch and Dr. Travis. We will go ahead and we'll have a few minutes here to take a couple questions before we wrap everything up. All right, so we'll start off here. Where would you recommend the VX be performed?
Where would the biopsy best be performed?
Yes, thank you.
So it's important for the surgeon to biopsy multiple lobes. It's ideal for the surgeon to actually be looking at the high-resolution CT during the biopsy procedure and to sample areas of different severity, so not to only biopsy honeycombing, but also areas of less affected lung. If the surgeon only biopsies honeycombing, or severe fibrosed areas, it makes it difficult for pathologists to classify the process.
Great. Now, does the presence of ground glass help distinguish between UIP versus NSIP?
I'll take that. You know, the ground glass abnormality in this particular case was not very extensive. It was a little patchy, so it really wasn't typical for NSIP. And so in this particular case, I don't think it helped me. If we had had more, you know, lower lung predominant ground glass abnormality that was more diffuse, I would have used it a little more in my differential.
If I could weigh in for a second, it is a good question to ask about ground glass because in patients who have underlying fibrotic lung disease, there are complications that can occur, and they frequently present as ground glass attenuation, although far more extensive than what we're seeing in this case. And there's a whole differential that goes with the appearance of what looks like underlying lung disease from fibrosis with superimposed diffuse ground glass attenuation, which is also one of the types of cases that we review during the course.
All right, looks like we have time for just one last question real quick. Do we need honeycombing to definitively call UIP on CT?
The answer to that is yes. You know, in the course we go through the ATS, American Thoracic Society criteria for UIP diagnosis by CT. It requires very careful engagement by the radiologist in reviewing all of the images, and certainly honeycombing is one of the most important signs for making this diagnosis.